Hello, and welcome to the McKnight's webinar, Reducing Aerosolized Pathogens in PM 2.5, Improving the Air We Breathe. I'm McKnight's home care editor, Liza Berger, and I'll be your moderator today. Our session's featured speaker is Jesse Coiro, Director of Growth and Strategic Initiatives for Erlab. I will introduce him more formally soon, but first some housekeeping matters. The slides will be available for download today. If you have audio problems, please first check the volume control on your device, as this is the most common cause of hearing problems. Please note that the sound is coming from the computer speakers. To submit a question for discussion for the Q&A later in the presentation, click on the button and type in what you want to ask at any time starting now. This presentation has been approved for continuing education credit. To receive credit, you must view a minimum of 50 minutes of the webinar during the live event. Once you have achieved 50 viewing minutes, a View Certificate button will display, and the required viewing duration will have a green checkbox. You can then view or save your certificate. If you provided a valid NAB ID number, which begins with the letter R followed by 7 digits, and registered for the event with the exact name associated with your NAB ID, your credit will be reported to NAB on your behalf within 5 business days after the event. We'd like to note that this program is made possible by support from Erlab. Learn more at their website, halo.erlab.com. Finally, this session will be archived and available on demand shortly after the live broadcast. You can access it again, or others can experience it for the first time by going to the registration page to enter the studio. The URL is mcknights.com/021821 webinar. Now to our presenter. Jesse Coiro has over 20 years of experience in providing solutions to the biopharma, pharmaceutical, medical device, and educational markets. His specialty is filtered solutions for the protection of personnel, facilities, and the environment. Jesse also has experience working with some of the world's most prestigious hospitals, helping develop plans to adhere to USP 797 standards, while also providing solutions such as environmental monitoring, sterile processing, and proficiency testing. So Jesse, long-term care already has a lot to worry about when it comes to protecting residents and staff during this pandemic. But judging by this presentation, it seems they need to keep air quality in mind as well. Is that correct?
Of course. It's a big concern. Today, we're very concerned about the air we breathe, and rightfully so. When we first were introduced to the unfortunate circumstance of COVID-19, the initial concern was contact transmission via formite and remaining 6 feet apart because of the droplets that are released from our mouths when we talk, when we sing, when we breathe. However, as this disease has evolved, we've learned a lot more. It's very fluid. We're learning every day. And what we've learned is this virus itself specifically is airborne. And what makes the virus airborne? When a droplet is released, it becomes aerosolized. These droplets that are aerosolized are between 5 to 25 micron in size. At that point, that's when we're in close proximity to someone, when they speak, that's when we can be infected, and then those droplets will land on a surface, and that's where contact transmission takes place. However, these droplets desiccate fairly quickly, and they become droplet nuclei. Now, droplet nuclei is between 5 micron down to 0.125 micron in size. And as these droplets become droplet nuclei, they like to remain suspended in the air for up to 16 hours or longer, right in the airstream in which we breathe. And we need to figure out a way to control the risk of airborne transmission so that we don't have these pollutions coming into the air we breathe, as our lungs and our nose mucous membranes can no longer filter out these virus droplets because they are so small. And in fact, the successful infection equation is the exposure to viral load concentration times time. So the quicker and more efficiently we're able to reduce these droplet nuclei, the more we reduce the risk of transmission. But we need to understand how to do that. And it becomes very complicated because there's a lot of different technologies on the market, and we need to make sure we develop the proper mitigation strategies to be able to provide the right mitigation plan. Now, it becomes more than just viruses. We have to also consider the effect of PM 2.5. So we have to address the air holistically. It becomes a holistic approach. While the virus really helped us be aware of the air we breathe, now that we're aware, we need to do something about it. And in fact, and specifically in long-term care facilities, we're looking at a reduction of 15%. It's 190,000 residents that are not admitting to long-term care facilities because of the risk factor involved with being in these long-term care facilities because of the high transmission rate. So there's a couple things going on here. Obviously, the risk of the residents and their health, the mortality rates, the risk to the staff members, maintaining proper staff so that we can help the residents we have within our facilities. We have to address this air. So furthermore, how do we address PM 2.5? We need to understand the importance of it. So we started with the virus. Now we have to talk about PM 2.5. Now, as I mentioned, the virus itself is between 5 micron down to 0.125 micron in size. And just to kind of give you a snapshot of what that means, human hair is about 50 to 70 micron in size, and beach sand is between 90 micron in size. PM 2.5 is indeed the unseen dangers. And these are particles we can't see, but they present significant inhalation effects and attributes to chronic disease such as asthma, heart attacks, bronchitis, and respiratory problems. And those with underlying conditions, it has a bigger impact on. Somebody who has asthma or an elderly person that's dealing with respiratory issues already, PM 2.5 will affect them much more severely than it would a healthy individual. Furthermore, exposure to PM 2.5 itself has been linked to higher COVID-19 infection and mortality rates. And that's right off of the NIH website. So again, we have to address the air we breathe holistically. From the virus standpoint, which goes far beyond COVID-19, we're looking at influenza, we're looking at bacteria, we're looking at mold, fungus spores. There's a lot going on in the air, and it has to be addressed. So what I want to talk about is really the global burden of disease and how it attributes to indoor air pollution. So there were studies performed well before this pandemic, back in 2015, that directly linked the global burden of disease to ambient air pollution, both outdoors and indoors. And then after the pandemic, or during the pandemic, we're still in it, Dr. Chan from Harvard wrote an article linking air pollution to higher COVID-19 death rates. We have to look at the facts. We look at New York as being the epicenter. Why? A lot of different reasons, but one of the reasons is the air they breathe, both outdoors and indoors, is extremely polluted. And you don't know it. You could be a healthy individual, exercising every day, going out for a run, going out for a bike ride, but you're only as healthy as the air you breathe. So if you're getting in contact with this PM 2.5 consistently, the cumulative effects of that exposure will degrade your health over time. And in fact, over 7 million people die prematurely every year from air pollution, both household and outdoor. Of that 7 million, 300,000 of it is right here in the United States. So this isn't just a third world problem. It's a problem that exists right here in our backyard. Of that 300%, that 300,000, 34% is due to heart disease. 20% from stroke, 21% due to pneumonia. So again, this in of itself is also a pandemic. It is an unseen danger, and it needs to be addressed. So let's go over some of the CDC and ASHRAE guidelines for engineering controls to improve indoor air quality. As we know, it's a concern for many on the call today. As per the CDC, they want to optimize air handling systems to ensure appropriate directional airflow patterns, appropriate filtration is integrated into the ventilation system, and they have the appropriate exchange rates, so air exchange rates. That's the amount of times you have outdoor air coming in and processed out continuously. They also want to consider the addition of portable HEPA-filtered units to supplement the existing HVAC system. As per ASHRAE, they too want to operate HVAC and improve ventilation, but they want the HVAC to be operated 24/7. They want the outside air to be increased to as close to 100% as possible. Sometimes this is not achievable. They also want an upgrade to the MERV 13 filters. So there's filters placed inside the ventilation system that will filter out pollutants within inside and filter out the pollutants that come from the outside air. So they want those to be upgraded to MERV 13 filters, and I'll get into MERV rated filters further down in the presentation. And again, ASHRAE also wants to use supplemental indoor cleaning systems such as HEPA filtered systems as well. There's a lot of impact involved in all of these recommendations. As it relates to your facility, air handling units, how can you optimize it per the guidelines, and where do you start? It's very challenging. What is the cost associated with increasing my air changers and increasing my outside air? And what is the added cost to my heating and cooling loads? Also, what is the impact as it relates to relative humidity? All this is impacted as we increase air changes, as we add upgrades to filtered systems. We have additional pressure drops on the unit itself, so we have higher load factors. And then, how do I zone my isolation rooms from the other occupied spaces? And I say that because a lot of these ventilation systems are centralized. So if you have an isolation room, you have a positive COVID-19 patient in that room, and your air handling units or your ventilation system is centralized, well, those pathogens are going up into the return vent through the HVAC and potentially re-entrained to other places within the facility or other supply vents into another room or in the corridor, wherever it may be. So we have to figure out how do we isolate these rooms. And then we have to look at how do I provide a solution without upgrading my ventilation system? Is that even possible? And what are the technologies available to me to do so? As it relates to the residents and staff, obviously, how can we control viral transmission between residents and staff? That's key. We want to maintain a safe environment, or as safe as possible as we possibly can. How can we address psychosocial factors of isolation? This is a major concern, and we know this because we're working with some long-term care facilities, and this has been a concern. When we have somebody in isolation, how do we address the psychosocial factors? How do we at least reduce the pain that they're experiencing by being isolated? Are we able to open up the doorways so they can at least see outside of the hallway? And if we do that, how can we ensure that we're not exposing those outside in the hallway? So there's a lot of things to consider there regarding the residents. And then cost of isolation as it relates to quarantine. I think on average, based on the information we've received from the facilities we're working with, it's between $200 to $500 a day per resident that's in isolation. And that's just gloves, gowns, disinfection, things of that nature. So what is the cost of isolation, and can that potentially be reduced? And are my sanitization initiatives enough? How can they be improved? So a lot of things to consider there. So what I want to go over is the technologies available to improve indoor air quality, how they work, the viability behind all of these different technologies, and the truth. And we'll get into some quantitative results and the performance criteria of some of these products later on in the presentation. So the first technology I want to discuss is upper room UVGI lighting. Traditionally, this has been used in tuberculosis isolation rooms where you have the right proper directional airflow patterns. It's effective. Upper room UVGI is extremely effective, but you must make sure you have, again, effective room distribution patterns, and you have the proper residency time within the aerated zones. Total dose required is based on the specific microorganisms to be inactivated. And again, the directional airflow patterns. If you don't have proper airflow, upstream airflow, how are we getting the pathogens to this upper room UVGI? So again, a lot of things we have to look at when we're trying to decide which types of technology to integrate into your facility. And there's additional information right on this link that will be available to you when you download the presentation. The next technology is ionizers or needlepoint bipolar ionization. This is a product that works. It is effective, but it's limited based on needed airflow. And what you see here on the left of this slide is this blue bar goes across the air handling unit. So typically, these needlepoint bipolar ionization systems will sit at the air handling unit, and it's based on how effective we are at pushing the air past these ionizers to drive the ions down through the HVAC system and then eventually to the rooms. However, the problem is there's density factors. As the further away the ion gets from the generator itself, the less effective it becomes. And in fact, the ions have a kill rate which ranges between 30 and 60 minutes additionally. So if you're not getting the ion to the source of the problem quickly and efficiently, then by the time it gets to the source, you then have a 30 to 60 minute time frame before it actually will kill a pathogen. But again, ions, when they're generated, have a lifespan of 60 seconds. So it's all about how do we get those ions to the air. They work if they're at the air handling units and you're looking to provide a solution within the HVAC system or deactivate the filters themselves. They do have value if you understand why you're implementing them and you know exactly what the needs of these ions are. They're not going to provide room level mitigation installed in the HVAC system. Also, some do generate ozone. So again, to recap, it is effective within the HVAC system. It will decontaminate the filters within the ventilation system as well. But if it doesn't have an effective source for proper dispersion methods, it's not going to provide you room level mitigation, and we really want to address the room. The next technology is an upgrade to the building's ventilation system or upgrade to MERV 13 filters. Now again, we understand how ventilation works, and if you don't, there's a quick diagram here. You have outside air that comes in, that gets processed, it gets filtered, and then you have supply air, which is air that enters the room. Then you have return air, which is the dirty air, the processed air that is returned back into the HVAC system, and it's a continuous process. So within this ventilation or this air handling unit, that's where you have the filters. You have a filter to filter the outside air, and then you have a filter to filter the return air. If you don't have the proper filter, now MERV 13 filter is what is required by ASHRAE, and that's because it has an efficiency rating of 75% to particles down to 0.3 micron. If you have less than that, basically those pathogens are going to fly right through this filter and then be released into the supply air. That's why the upgrade to the filter is critical and part of the recommendation for CDC and ASHRAE. Now, most systems will not allow for a filter upgrade. If you put a more robust system, a more robust filter in a system that was rated for, let's say, a MERV 7 filter, it's not going to be able to handle the pressure drop when adding a more heavily pleated filter such as a MERV 13 filter. So we have to factor that into our plans. And if upgraded, again, what is the impact to the heating and cooling loads? So MERV 13 filters, again, I told you I would discuss the MERV rating filters later on in the presentation. As I mentioned earlier, the MERV 13 filters are about 75% efficient at capturing viral particles as small as 0.125. 75% is not great, but it's not horrible. If we look at a MERV 7 filter, which is the standard filter that's usually within facilities and how an HVAC is designed, you have less than 20% efficiency at microns smaller than 0.3. As you get larger in the micron size, it becomes more efficient, obviously because the particle itself is larger. But then we have to get into HEPA filters. HEPA filters start at MERV 17 filters and above. That's when we become 99.995% efficient and greater. So basically, the higher the MERV rated filter, the more efficient the filter is at capturing particles between 0.1 micron and 1 micron in size, and that's the danger zone. But again, just like the UV upper room UVGI, or just like the needlepoint bipolar ionization, this does not address room level mitigation. Again, if it's centralized and we don't have the proper filter in the system, those viruses could potentially be dispersed right back into the supply. The next technology that I want to mention is floor filtered units. These are a very, very affordable system to integrate into your building. It plugs in. But there's a lot wrong with these systems. They're meant for residential use. Now remember how I mentioned the virus remains in the air for up to 16 hours, right within the breathing zone. Floor-mounted systems do a couple things. They create ground distribution and air turbulence, and they create a very unpredictable airflow pattern, which increases the chance of exposure because it takes the air, it drives it down past the breathing zone, it then creates a very turbulent environment, which then can further desiccate any of the droplets that may have potentially landed on the surface, and then just create an environment that's full of infectious droplet nuclei. When it captures, and if it captures those droplet nuclei in the filtered system, depending on the filter, it may capture them efficiently. But it's far further than the filter. We have to, again, understand ventilation effectiveness, the way the air is processed, the patterns of the airflow. So by far not the best solution for a commercial use space. And floor UV units. So yes, there's a lot of different technologies out there, I understand, but that's what's available, and I just want to make sure we educate on all of these different technologies. So these floor UV units, again, can be easily turned off and interrupted by furniture or personnel, just like a floor filtered unit. The airflow draws contaminated air down past the breathing zone. It creates ground turbulence and inadequate distribution and very unpredictable airflow patterns. Now, UV lighting, you have to understand, just like the ionizers and just like upper room UVGI, there is a total dosage factor that needs to be equated to reduce the pathogen load. If we're drawing a tremendous amount of air through these systems, they call cubic feet per minute, there's not going to be enough residency time for that pathogen to be exposed to the UV light for it to be deemed effective. And simply put, there's just not enough exposure. The WHO advises against the use of these products, and the inefficiencies have been recognized. In fact, there was just a $6 million investment made at the Sacramento City Unified School District for 480 of these units without investigating the efficacy and the performance of the product. Now, the school committee, the teachers' unions, everyone involved is looking to return the product because they were sold something that really wasn't going to be able to provide them the right solution. And that's unfortunate. It's unsettling to know this is occurring, but it is. So we have to be aware and be very educated of what is available to us on the market. Now, this piece of equipment, large room UVC, maybe you have seen these as robots. iRobot has partnered with a company that literally takes these units to an unoccupied space and delivers UV continuously, which provides a 16-foot kill radius for every 1,000 square foot room. It's a great solution for unoccupied spaces. It does provide the proper dosage time to deactivate any pathogens present in that room, and it's easy to use. But again, it's effective and a great solution when a facility or a room is unoccupied. You cannot use a system like this in an occupied room. We cannot be exposed to these UV wavelengths. So extremely effective, but it's not going to address the air, and it's certainly not going to address the pollution factor in the room itself when you have an occupied resident or if you're just in general operating spaces. Then there's ceiling-mounted self-sustainable air filtration systems that are not integrated into the HVAC system, and they just process the air. These provide room-level mitigation. They capture viral particles, generalized pollution, PM 2.5 at the source, and they draw air up and away from the breathing zone of the occupant, which is extremely critical. When they disperse the air, so they drive the air up vertically, they disperse it horizontally and create what's known as a Coanda airflow effect. And as you see here in this diagram, it basically creates an airflow curtain, and it ensures that we're taking all the polluted air that's down and around, up and away from the breathing zone and continuously to move the air. In addition, when properly outfitted, now depending on the room size, will determine, like all of these products I mentioned, will determine how many units are required. So depending on the room size and the number of units installed, it will add an additional 3 air change rates per hour, again without upgrading the building's ventilation system. It also can improve room mixing, or what's known as ventilation effectiveness, or VEF. When you have proper room mixing, you have a very adequate airflow system that is, again, designed to mitigate any problems present, whether pollution or viral or non-viral, within the room or the facility. And there's been further research to show the log reduction of greater than 90% of viruses within 15 minutes. Now, you remember further back I mentioned needlepoint bipolar ionization. It works if you have the proper dispersion. So these systems do have optional needlepoint bipolar ionization systems where it's installed within the cavity chamber between the filter and the fan. So we're constantly dispersing negatively and positively charged ions while we're filtering at the same time. This becomes extremely efficient. Now, how can these technologies work together, and when does it make sense? So again, let's try to wrap our head around all these different technologies, and let's understand first and foremost, again, how do we address the room when occupied? Couple of solutions: the ceiling mounted system with needlepoint bipolar ionization combined, or you have upper room UVGI if you already have proper airflow distribution. Those are room level mitigation solutions, and of course you have the UVC, we'll call it the robot, when the room's unoccupied. And what's going to provide you with dirty to clean air distribution patterns? Proper dirty to clean air distribution patterns. Again, taking the dirty air up and away from the breathing zone. Well, that would be a proper ceiling mounted filtered system, just as it would provide very predictable airflow patterns, and it increases ventilation effectiveness. Now, ventilation systems will do this as well if it's designed appropriately. We're assuming that your ventilation system may not be able to be upgraded because that seems to be what we're coming across more and more every day. It can also increase air change rates, both the ceiling mounted system as well as an upgrade to the ventilation system. Then we have to look at what decontaminates and what deactivates. Well, ionizers can deactivate, UVGI can decontaminate and deactivate, and so can a robot UV system. You can also deactivate with ionization integrated into the ceiling mounted system. Now, with HEPA filtration, remember we're capturing these viruses. It can be influenza, could be COVID-19, whatever it may be. When these viruses are captured, if they don't have a source, they die rapidly and they desiccate over time, and they'll never be released from the HEPA filter itself as long as it's a medical grade H14 or better HEPA filter that's installed, what's known as an ULPA filter. They will not be released. So once they're captured, it's not like when the filter's changed, you're going to be released with these pathogens. They will cease to exist and they'll just remain a particle on the surface of the HEPA filter itself. So now we want to review efficacy studies and true quantitative results, which is critical. We need to know that the solutions we're integrating into our facility are going to work. There has to be studies behind the technology to prove its efficiency and its effectiveness. Otherwise, we're going to make investments like the Sacramento School District and others and unfortunately be stuck in a very bad situation where we don't have a true adequate solution. So I'm going to go over some efficacy studies of pre-validations of particle counts in a controlled challenge test atmosphere and uncontrolled real-world conditions. We're going to look at post-validation of particles. So after the technology is integrated, what have we seen in regards to reduction of particles? Then we're going to look at real-world data and sample collection of actual SARS-CoV-2 using polymer chain reaction, or PCR, in an active COVID-19 patient's room where we ran A/B testing. And then we're going to go over some challenge efficacy tests against aerosolized MS2 viruses. And MS2 is used as a surrogate virus for influenza and now has been approved also for COVID-19. And then we want to look at the overall testing and efficacy of the improvement of ventilation effectiveness to ensure we are mixing the room adequately and the air is being processed effectively. So these first graphs are going to show you, the one on the left actually shows you a real world scenario in an office space where we wanted to take particle counts when the room itself was active. It's about a 2,700 cubic foot room, and we wanted to take a baseline of the particle counts before. Now this is just particles, these aren't viruses. We just wanted to take a baseline of the particle counts before, and then we wanted to take a baseline after a ceiling mounted system was installed. And what we saw with the baseline before, at the particles that really matter between 0.3 and 0.5 micron, we saw 896 million versus 253 million. So we saw a greater than 74% reduction across the board on the smaller particles. Then you want to test the overall log reduction and the viability of and the efficacy of a system when it's put in a controlled chamber and you inundate it with a pathogen or an MS2 virus. And you want to see how long it takes you to actually start getting a log reduction, and over the time of the testing, when do you achieve a 4 log reduction, which is a 99.99% reduction of pathogens. And this test showed that during this the baseline, we ran a baseline test, and then after we ran 3 individual tests thereafter, there was a log reduction of an average of 1 within 15 minutes, and then decreased significantly from there. After the test within 90 minutes, there was an average of a 4.99 log reduction. A challenge test, not real-world settings, but it absolutely is a challenge test where this chamber literally gets dosed with MS2. So you have to look at the overall effectiveness of that. Doesn't tell the whole story, however. The charts to the graphs to the right here, I've already shown you this chart. These graphs to the right and the bottom will show you a real-world setting of particle count in a warehouse space. And we're talking about room level mitigation, patient's room, which average between 250 to 500 square feet. But then we have to look at general facilities, corridors. We go to congregation areas. How effective can a system be? Well, what we saw here was a general log reduction of greater than 80% across the board, from 0.3 microns down to, from 1 micron down to 0.3 micron. That is a significant reduction. Now, this was 186,000 cubic foot warehouse space with 8 systems installed. Now, when I mentioned technologies working together, we did work with the ventilation system here as the systems were installed near the return registers. Remember, we have return and supplies, so the air that's being sucked up, we were working with that air, those CFM, that air volume, and we installed the ceiling mounted system working with that CFM, and we were able to control the airflow patterns and drastically reduce the particle counts. Now, these are particles. Again, we're talking viruses and particles. Particles are critical. PM 2.5 drastically reduced, and that's what we want to look at. The additional real-world data in another uncontrolled atmosphere is where we ran A/B testing. We wanted to know what the results would be from a COVID-positive 19 patients room with a halo versus a positive patient's room without the halo. The results we saw were staggering. I'll go over those results. You see the schematic drawings here. We had room 118. This was a patient that was in isolation. We have without a halo. You see the supply, so this is the air entering the room. The return, this is the air exiting the room. In room 120, same. You had the supply and the return, and then a halo installed in the center of the room. Patient in room 120 was just at the start of their quarantine. Patient in room 118 was towards the end of the quarantine. We know a couple of things. Based on the fact that this patient in room 120 was at the start of the quarantine, they were shedding a significant amount of viruses. We know that because we took swab samples at the foot of the bed, at the window shelf, and we wanted to see, again, the positive RNA copies. We're looking at N1 and N2 positive proteins. At the floor, we saw 23,000 copies. I mean, this patient was shedding a massive amount of viruses. We saw 820 at the window shelf. In room 118, the patient was at the end of the quarantine, so the viral shedding was minimal. We saw 3,500 copies at the register. We did not see any at the floor or the window shelf. So A couple things. We know this patient, room 120, was shedding virus. We know this patient 118, if they were shedding virus, it was extremely minimal, and we know they were towards the end of quarantine, so the chances of cleaning and sanitization was high. We didn't get the cleaning logs. This testing was taken at Avamere Healthcare Associates in Boise, but we do know that the patient wasn't shedding a significant amount of virus. The data that we'll really want to look at is what we saw in the supply on both rooms. What this tells us, nothing was detected at the supply. Now, this was a centralized system, so the air feeding room 120 was the same air feeding room 118. So that's good. However, what we saw in room 118 at the return with the 3,500 RNA copies was kind of alarming, knowing that this virus specifically is airborne for a long time. Seeing the swab samples at the return register and within the airstream with 3,500 copies, with no detectable RNA at the window or the floor, was very alarming. It's saying, okay, this virus is in the air for sure. This proves the virus remains in the air. However, patient in room 120, there was no detectable virus at the return register or within the airstream. So it proves the efficacy, furthermore, in a real-world setting of the ceiling-mounted system. So one more thing I want to mention here. Avamere, when we were discussing the testing, a lot of their concerns was psychosocial factors. Again, I do want to address this because it was something that we really were not aware of. How do we address psychosocial factors? How do we ensure that the patient at least have some sort of visibility outside of the four walls that they feel are closing in on them? And if we can address the air effectively and we can reduce the fact that the virus can be spread through the air, would we be confident in opening up the doors to the hallway, at least so that can be eliminated from the already unfortunate situation they're dealing with? And then they were very concerned about the staff. We know that long-term care facilities, senior living facilities, are having a hard time keeping staff because of the fear of infection, obviously. If they are able to address the air and have a mitigation solution with validity behind it and quantitative results, would this allow them to improve their staffing? Would they be able to retain the staff members that they have? And furthermore, will they be able to have the residents' parents and family members be able to visit them again? There's a lot going on here, and again, a very fluid situation. So again, it's critical to understand what needs to be done to address all of these issues, the cumulative effects of it, the impact it has on the residents, the staffs, and the family members. So in summary, we look at the solutions that deal with today's issues, but also look forward to tomorrow's challenges. And what are tomorrow's challenges? We're well aware that there's a vaccine available, and people are getting inoculated very rapidly, but there's also mutation occurring. There's a lot of variants of this disease happening frequently. How long will this vaccine last? Will it be effective to the next variant? And what happens when the next virus comes? And unfortunately, there will be more coronavirus that occurs. There was a doctor at the University of Texas Children's Hospital that said, rest assured, this is not the last that we see of a mutated coronavirus. We have to learn from the lesson. We have to learn from the lessons that we've been given from this pandemic. We don't want to be put in this situation again. So again, when I say we have to address today, but we have to look at tomorrow's challenges, it's everything I just mentioned, but also the general pollution that we really weren't addressing before this. We also learned that filtration, when used appropriately, does provide significant impact to the overall ventilation effectiveness and reduces PM 2.5 and overall viral load. What we don't know, and I would be remiss to say that we know that a certain amount of viral load will impact an individual differently. That's not true. We don't know the amount of viral load we need to be exposed to in order to be infected by this virus or any virus really. All we know is if we reduce viral load concentrations, the chances are decreased. So we want to reduce the overall viral load as effectively and as efficiently as we can. And again, while there are many options available and some that look appealing due to cost, we know cost is an issue. Have to look at the data to determine the best solution for your facility so that you don't make a regrettable decision in purchasing and spending a tremendous amount of capital on a system that doesn't work and just provides a placebo. It's the last thing anybody wants to do. We also learned that pollution does play a significant role in the global burden of disease, and we can't continue to look at dilution as the solution. So there is also where filtration can contribute and benefit well beyond, especially well beyond the laboratory world, but into commercial spaces, into long-term care spaces. So there's a lot we learned here, and I'm here to answer any questions and willing to answer any questions you may have.
Great. Well, thank you so much, Jesse. That was really interesting and gave us lots of good information. Now we are opening up the floor to Q&A, to questions, and we've got some already, but please feel free, you in the audience, to give Jesse some questions. He's here to answer whatever questions you may have. Here's a small one, or it's one that might be easy to answer. What does RNA mean in one of your previous slides?
RNA, so you have DNA and RNA. It's what our body is comprised of. So RNA would be, and this is an RNA single-strand virus, and we have to understand that. So the RNA virus, just like the flu, is what the virus is made of, and it's how it reacts to our body. And with RNA single-strand viruses, it depends on the individual's RNA itself and how it impacts, and that's why we're seeing such a variation of how individuals are impacted by this virus, and even how individuals are impacted by influenza itself. If you have a different RNA strain than somebody else, which you do, it's going to depend how it works, right? It's a very complicated system. DNA, RNA is extremely complicated. So with the single-strand RNA, again, we have to also understand that it will mutate in the individual's bodies differently, and it will mutate over time, as a virus's whole point is to infect. So what we're learning now on this RNA virus is the proteins that cause the infection are called spike proteins, and we're learning now that this spike protein is kind of mutating a little bit. Traditionally these spikes are kind of curved down. Think of a flower bud. Now we're seeing that this spike is opening up, and when this flower bud opens up, it will attract to specific points within your body and your RNA structure, and that's when infection occurs. Now you have antibodies, and an antibody will act as a barrier between that spike protein and your RNA. As these spikes change and mutate, that antibody that may have been protecting you can no longer protect you because of the mutation of the spike. It's a very complicated system, but it's intriguing to learn and understand. Sorry, may have went in a little deep there, but hope that answered the question.
No, a little science, nothing wrong with a little science. So we got a couple kind of similar questions. Really, what do you recommend for a whole building solution or a senior adult facility?
So a couple things, whole building solution. First and foremost, we look at the ventilation system. Can your ventilation system be upgraded without extensive costs? You already have a ventilation system there that's providing filtration and air change rates through the whole facility. So first step is let's look at the ventilation, and can we upgrade it? Can we upgrade the filters? Can we increase our air change rates? And is it possible to zone this ventilation system? So if we have isolation rooms specifically, can we zone these isolation rooms to other air handling units? Then if the ventilation system is old or it cannot be upgraded easily without significant cost. Now, the cost to upgrade a whole system, if you were adding new air handling units, increase in air changes, upgrading a system to handle a MERV 13 filter, and you don't already have something in place, we're talking millions and millions of dollars. So if the ventilation system isn't going to work for you, then you look at a whole room system that can be a combination of HEPA filtered, as CDC and ASHRAE has recommended, a supplement with HEPA filtered solutions. That's going to provide you the proper ventilation or increased ventilation effectiveness or air change rates. And then you can also look at other technologies like UV. As I mentioned, if you want to provide additional decontamination of the isolation rooms after a patient leaves, just to have, when you wipe down surfaces, you may miss spots. But same holds true with UV. As UV is dispersed, there's shadowing. As you have beds and counters or whatever it may be, and you don't have the UV rays going right underneath the counter or right underneath the bed, that too isn't going to be disinfected. So it's really a multi-pronged approach: ventilation, filtration, increase of air changes, proper disinfection and sanitization, and if necessary, UV if you feel it appropriate. So again, a very multi-pronged approach needs to take place.
Very good. Now, does that answer also apply to the senior adult facility?
It does, absolutely. It applies to all facilities. If it's senior adult, long-term care, hospitals, school settings, it really applies to all.
Very good. So here's a question I bet that's on the minds of a lot of our listeners. I mean, they're already these facilities are under a lot of financial pressure as it is. The question is, how do we get long-term care facilities to buy into using these systems to improve airflow, as they are already under such, intense financial and staffing pressures?
Oh, it's a great question. I wish I had the answer. We're working with a lot of facilities that have received grant funding. That, of course, helps. We're also seeing that facilities are starting to be incentivized. I had a conversation with one of the board of directors at Avamere yesterday. They're starting to be incentivized for COVID-19 patients that they accept into their facility. I think they said $13,000 per patient. So there's some incentives being provided to facilities, but I don't have the answer to all because I don't know. It's very fluid. It depends on the district. It depends where you're located. It depends on the grant funding. It depends on the size of the facility. So I don't have the silver bullet answer there, unfortunately. Mm-hmm. We just have to work with each individual facility to really try to come up with the best solution and see if there's any way we could help reduce the financial burden. There's also finance programs available. We do know this: if you keep reducing the level of residents that are inside long-term cares, we're a 50% reduction as we stand today based on an article from the Wall Street Journal, and that's continuing to decline because of the fare. If we don't subdue the fare, there's going to be more financial repercussions. So there has to be collectively a solution on how we get back to capacity and how we provide a safer environment for all.
Okay. More of a technical question now. What if you have a new building? Could you address having a new building with a new system? That's kind of the question. Maybe they're asking, what would you recommend if you're able to build a new building, and what would you do if you kind of had the world was your oyster, I guess, at that point?
Well, if you're building a new building, absolutely. You need ventilation anyway. You can't do away with ventilation. So if you have the ability and the world's their oyster, design it so you have an effective ventilation system where you have controlled atmospheres for specific isolation rooms. You have proper air change rates, which is between, as per ASHRAE recommendations, 4 to 10 air change rates. And you have the proper filtration added. That's where you would start, for sure. There's no question about it. Then after that, if you feel like you have to have other mitigation plans implemented in place, then you can go with different room level strategies. But yeah, if the world's your oyster and you have the ability to build a new facility, start with the right ventilation. The problem is a lot of the facilities are not, they have very old antiquated systems and they're just not able to upgrade.
Right. This person, that's a great answer. This person asks, who's the best person or what is the best profession to assess and advise regarding mitigation measures in a quarantine room or area? And maybe they're asking what position or what person should you bring in to take a look at this?
An outside specialist. There's a lot of groups out there. Microbiologists. You have hygiene resource companies. The people who tested Avamere was Industrial Hygiene Resources, so it was a third party who's focused on ventilation and understanding the complexities, the challenges that are faced, airflow patterns. So you'd want to bring in a source that has technical expertise in ventilation to know where these samples need to be taken, know how the ventilation system works, and have a third-party accredited source perform that testing.
This person asked a pretty specific question. Would you please address the addition of DOAS units with or without energy recovery to existing buildings that do not have upgradable HVAC systems as a strategy to improve the ACH rates? Maybe you can unscramble all those letters for everybody.
Could you say that for me one more time?
Yeah. Please address the addition of DOAS units with or without energy recovery to existing buildings that do not have upgradable HVAC systems as a strategy to improve ACH rates. Is that alphabet soup to you too, or?
Yeah, I'm not quite understanding the question.
Okay.
Could that person elaborate a little bit more?
Okay. Well, maybe I'll see
if they could, if they would, or if they want to send us an email, I'd happy to address it.
Okay.
But it's not making sense to me.
Okay, we'll move on to another and see if they get back to us. The simplest filtration system that you would recommend in a ventilator unit.
The simplest filtration that I would recommend.
Yeah.
Would be the ceiling mounted system, because you have to look at the effectiveness. The simplest would be a plug-in floor mounted system, but that doesn't work. Simple doesn't work all the time. The most efficient would be a ceiling mounted system that's above the occupant, so you're taking those droplet nuclei up and away consistently and efficiently.
We got a little clarification on the DOAS question, Jesse. DOAS is dedicated outdoor air system, a unit supplying cool, dehumidified outside air to the building in summer and a heated outside air in the winter. The system can also include total energy wheels. So would you want to comment on this? Can you please address the addition of this dedicated outdoor air system with or without energy recovery to existing buildings that do not have upgradable HVAC systems?
How do we address that? I'd have to take that offline, to be honest with you. That's a very long, antiquated answer.
Okay.
It's very long.
Got it. All right. And that's fine, Jesse. We'll get back to you with that. Let's see. And so here's a question. What do you do if you already have all the other non-effective apparatuses, like the floor air exchange with, I think, UV light is what they're saying?
What do you do if you already have them?
Yeah, I guess what's next? Maybe.
What's next? Well, unfortunately, there's been a cost associated with that. You'd have to address it and say, we've already had a cost, the capital cost expenditure for these systems. They're deemed inadequate. The only option is to return them if you can, or spend additional resources to get an adequate solution. Nothing else you can do there, unfortunately. I do know the people that have purchased these systems and have been presented falsified information are going deep into the process of returning them and taking legal action. But again, that's going to be an individual's preference on what they want to do there and how they want to act on that.
Mm-hmm. Another question that I think you've covered, but it doesn't hurt to talk about it again. Would you comment on or weigh in on the most cost-effective solution for a 1,450 square foot unit and a 2.1500 square foot common space?
Well, the most cost effective, again, you got to look at what you already have in place. Can you utilize what's existing, your ventilation, and if you can't, we have to supplement it. The most cost effective solution, again, we have to look at cost, but you also have to look at performance and efficacy. Now, based on what we know in the efficacy studies we've performed, we know what works. That is a ceiling mounted system, and that's just due to the airflow, ventilation effectiveness, room mixing, the filtration that's used behind the system itself. That would be the most cost-effective and effective solution to use.
Very good. And then let's end with, I think we have time for one more question. Let's end with what we know at this point on COVID-19 on catching the virus by air versus contact with surfaces. What do we know? Do you have an answer? What's the latest on that, Jesse?
It's funny, when this started, it was all about washing your hands, surface decontamination, 6 feet apart, don't touch anything, don't rub your eyes. Obviously, we still want to be very cautious there. I'm not saying don't wash your hands at all. It's not what I'm saying, but it's definitely transitioned rapidly to the air. It's airborne. It's in the airstream. There's no denying it. Unfortunately, we weren't guided in the right direction when this first came out. And now the CDC, they first came out with it's airborne, then they retracted the statement, then they came back out and said, nope, this virus is absolutely airborne. So now we are starting to see people really trying to address the air because that's how it's spread. That's the greatest risk of transmission. Of course, we have to be diligent. We don't want to rub our eyes and touch our mouths. Of course, you don't want to do that anyway, even without a pandemic. But it's need to address the air. There's no question about it.
Okay. Well, on that note, that will now conclude our presentation. We hope everyone has enjoyed this webinar. It will be available shortly at mcknights.com/0-1821 webinar. We'd like to give a very special thank you to Jesse Coiro and Erlab. Again, you can visit them at halo.erlab.com. We want to thank you, our listeners. You've provided terrific questions for Jesse. Thank you so much. And thank you again for joining us today. This is Liza Berger for McKnights.